Welcome to the True Health Tuesdays question and answers, or questions and responses on the lumbar. Question 1 from Barbara Ainsey. Dr. Bergman, how do you end up helping Barbara with her sideways torso? And this is referring to x-rays I showed on the True Health Tuesday video of Barbara, who dropped out of care after 6 months and then 7 years later came back after getting a surgical fusion. That's one of the more challenging. Now, I get patients from literally everywhere, all around the world. And sometimes they can only come for a few months or a few weeks or something, and then they go back. Now, this patient was with us on and off for a few months, and they had some work challenges, financial challenges. They had to move, and they weren't able to get the corrective care. And now in standard care, they're given medications to suppress the symptom. Now, when you look at Advil, Motrin, Aleve, those are non-steroidal anti-inflammatories, and those actually weaken the building products that the body produces called proteoglycan production. This is the building products that your body needs to build cartilage, ligaments, the structures. So when you're taking the standard medications to alleviate or to decrease the symptoms, to be comfortable, it actually damages the body. And then she got into the medical system, and that was a big challenge. What we did traction, but not just traction of the lumbar. You also have to reposition the thoracic. The 30% of lumbar issues generally come from forward head carriage or loss of curve. So you got to restore the curve in the neck in order to change the force loading on that lumbar. Then you've got to stabilize the pelvis, change the gait. I'm talking fixing the knees, stretching the calf muscles, stabilizing the pelvis. So you have to look at a lumbar issue as a systemic problem or a problem with the entire system. That's not all. Then you got to change the sleep patterns, the emotional component, diet, nutrition. So you're looking at the physical, chemical, and emotional stress load. When she came back with the surgery is a bummer because they literally bolted the lumbar to the pelvis or to the sacrum. And then that completely alters the pelvic dynamics. So now she will have an altered pelvic dynamic where the pelvis has to move in a completely different fashion because now the sacrum is bolted to the lumbar. And that sets up a host of negatives. And you can even see that the entire torso is shifted off more radically. So that means that there are some thoracic issues that weren't addressed with that surgery. And obviously the surgery didn't affix the lumbar, knee biomechanics, foot biomechanics. So the surgery of an area is to fuse that area. And it's not taken into account the altered mechanics that have to be addressed to correct the entire structure. And surgery cannot be undone. Although I actually know surgery can be undone. I've referred a couple of people back, particularly with surgeries in the cervical spine and upper thoracic spine, that they haven't altered the mechanic. Because a lot of times when they do a surgery, they have to actually remove parts of the bone, and they'll do what's called a laminectomy. Those surgeries, you generally cannot remove the metal bars or plates that they put in. I've had several surgeries where we've had to remove plates in the cervical spine because the screws negatively affect typically swallowing. And once you start to restore or change the biomechanic or the force loading on it, then the fusion of those bolts or plates aren't really needed. So question 2, Flame O Faya 2175. Damage to T11 spine. If this is the case, what are your recommendations? I don't know much about medical, but I do gain a lot of spiritual understanding through this video. God bless you. Okay, it's cool. You got physical, chemical, emotional stress. And if you know that your body is more energy than matter, the spiritual aspect is super important. It's a contributing factor. That's why you got to address everything. T11 is very, very important. That's at the base of the thoracic spine. Now, the spinal cord stops at a T12L1 right around there. So anytime you have damage close to that area, you're negatively affecting the end of the spinal cord. The end of the spinal cord, any damage to that is called cauda equina syndrome or horse's tail. So this can negatively affect any nerve supply to the gastrointestinal tract. And if you look at the rib cage, has a very, very solid structure. I mean, there's not a lot of motion there because it's designed to protect the heart and lungs. There is motion, though, if you've had a trauma and a lateral deviation, or if the cervical spine has been damaged, the body will compensate to allow that system to be more balanced. So when you're looking at T11, you've got to look at the entire structure. So you've got to see if there's loss of curve, forward head carriage, a rounding over or hyperkyphosis of the thoracic spine. That can negatively affect that area. Also, lumbar issues. This is why we do static and stress x-rays of the lumbar, where we're bending the body to one side, bending the body to the other to see the dynamics. Now, anytime there's a structural problem in the lumbar or thoracic area, typically that's going to change how the person walks. So the pelvis may be unstable. So when you've got this issue, make sure you have the chiropractor look at the dynamics of the foot. There may be loss of dorsiflexion, so that can change the gait. There may be pelvic instability. There may be lumbar disc injuries that weren't addressed. There may be a lateral translation or upper thoracic issues that haven't been addressed. There may be a forward head carriage that hasn't been addressed. I'd encourage you to look at our pelvic health video that addresses a lot of this. And in fact, we recommend a plastic water bottle of about 4 inches diameter. We give a foam, non-compressible foam piece about 4 inches diameter, and it's placed at the bottom of the elbow, the bottom of the roll, at that level. And we put it at that junction, the thoracolumbar junction, to restore the lumbar curve, which will, and then it also, by bringing in that lordosis of that lumbar, it also repositions the thoracic area and de-stresses out even the upper thoracic and the cervical spine. So this is why you got to look at everything, and that is a very, very important. In fact, D.D. Palmer, one of the founders of chiropractic, said the most important bone in the spine to adjust is D12. They call them dorsal, we call them thoracic now, but the vertebra right below that, and the reason that's so important is because that is the end of the spinal cord. The nerves continue on as a bundle of nerves, but that spinal cord is a long tubular brain. It has its autonomic function. It's very, very important. So looking above and below that area is going to correct the problem. Question 3, TSEY 13. Now, the comment is very, very long, so we've got the bullet points here. Severe degeneration at L3, L4, and L5, thinning of the vertebral disc. Thoracic spine is also degenerated with possible arthritic fusion at T10 and T11. Acute intense pain during flexion, such as the yoga child pose. Right leg, sometimes left leg, goes numb when sleeping on the back. Tingling sensation in both the legs when active. Can't sit comfortably and feels the spine is very unstable. Excellent. Let's look at everything, because this is a lengthy question, but it's also incredibly common. Degeneration. In order to see degenerative disc disease, which is also called degenerative joint disease, it's also called osteoarthritis, at L3, L4, and L5, there has to be altered biomechanics. This is the end result of a trauma. Now, when you have a trauma of that lumbar spine, that could be secondary to another trauma in the rest of the spine. And this is where a lot of doctors get confused. Like a person will have pain in the back, and then they'll go in and get an MRI. And the MRI is done when you're typically laying down, and they're looking at just that area. Now, the reason I say it's generally not specifically that area, the L3, L4, L5, that if you have, and just do me a favor, sit up nice and straight, translate your rib cage over just a couple of inches and just hang out here for a second. Where do you feel it? You feel it in the low back. So you can have a thoracic deviation, cervical deviation, And if you have any challenge in that lumbar, let me tell you, the muscles that you don't have conscious control over that run down either side of the spine are going to increase in tone to stabilize that area because the nerves that come out of there supply everything. It supplies the muscles, but you're also looking at organ supply, you're looking at autonomic supply. I mean, this is hugely important. So anytime you injure those nerves or alter the mechanics, the muscles are going to tighten up, limiting motion. And this is going to cause the pelvis to be unstable. This is why T10, T11, and again, when you've got arthritic fusion there, that means long-term problems. It takes 3 to 5 years to see a bone change on x-ray. When you've got fusion, that means the disc has been compressed and the bones start to fuse. So you're looking at an injury possibly 15 to 20 years old. And if I saw the x-rays, I could guess that. It could be more than that, but it would not be less than that. So you're looking at a long-term thoracic injury leading to a lumbar problem, or the lumbar problem came before the thoracic problem. So, you've got a challenge in all of those areas. Now, the reason child's pose is kind of like the fetal position where you're hyperflexing the spine, you're putting a lot of pressure on the abdomen, your hands are out. And when you're putting pressure on the stomach or on the abdomen area, you're increasing intrathecal pressure. And this, if there is any disc injury, you're actually forcing that disc material back. This is why putting pressure on that abdomen area can negatively affect sensitive discs or altered biomechanics, because normal people can put pressure on the abdomen and not have that symptom. But if you have a disc dysfunction, you're increasing that pressure. This is why also coughing, sneezing, that can increase and irritate unstable discs in the low back. This is also why when we're adjusting people, number one thing we do is we put them under abdominal suspension, where we support the pelvis so the lumbar has a lordosis. And what that does, that creates a negative pressure on the front portion of the disc, moving that disc material from the back where the nerve is towards the front. So it makes sense that hyperflexion would negatively affect this because you have evidence of disc issues. Right leg, left leg goes numb when sleeping on the back. That's because those nerves that supply the leg, we're talking the lumbar plexus, we're talking all of those, the nerves that supply the legs, the sciatic nerve comes out of the base of the lumbar and part of the sacrum. So all of these nerves that supply the legs, and when you're looking at tingling, electrical, burning, sharp, and shooting, those are all nerve pinch pains or nerve pains, neurogenic pain or symptoms. And this is why when you have that, it's not a problem in the legs. It's an alarm in the legs. It's a problem in the nerves that supply it. But then don't stop thinking there. Okay, so wow, leg pain, whether it's sciatica or whether it's on the front or the side, that's going to clue you into the disc that's involved, but it's not going to clue you into why the disc is negatively affected. So you have to look at the entire structure. That means you've got to look at the cervical, thoracic, lumbar, pelvis. You've got to look at the dynamics of the knees. You've got to look at the biomechanics of the foot. Typically, if this has been going on for a long time, the big toe should be leaning away from your toes. You're going to see the big toe leaning towards the toes and maybe even a beginning bunion formation too. That means that this problem has been there for a long time. When you got arthritic changes at T10 and T11, we know that there was a trauma there in the past that was over 10 to 15 years old based on the degeneration. If it's grade 2, you're looking at least 5 to 15 years of damage. If you're looking at grade 1, it could be shorter than that. If you're looking at grade 3, it could be longer than that. So, you're talking a significant injury that's been there for a long time. This is also why when you're doing a normal action, such as laying down, and you get symptoms, it means you're changing the force loading, and this indicates that there's a problem. Can't sit comfortably, obviously, because this means pelvic instability. When you look at the pelvis is the most brilliant structure ever. There's no muscle that crosses the posterior aspect of it, but you do have the piriformis that crosses the front. You also have the psoas muscle that crosses in the front area. So anytime you have pelvic hypermobility, And a lot of chiropractors are going to adjust the pelvis because it's nice, it's easy, it's big, you can adjust it, you get a pop. Okay, everybody feels great, except by the time the person drives from the chiropractor's office back home, the pain could come back. That's because the chiropractor isn't assessing the lumbar for the issue and just adjusting the pelvis. This is why we recommend stabilizing the pelvis, particularly in issues like this. And then you got to correct the dynamics of sitting. This is why we use that 4-inch foam piece or a plastic water bottle. Bottom of the elbow is the bottom of the bottle to increase that lordosis of the lumbar, de-stressing out the thoracic and the pelvis, and then a trochanter support to stabilize the pelvis. Now, typically, a trochanter support, I don't recommend lumbar supports because that negatively alters the biomechanics. Stabilizing the pelvis makes a heck of a lot of sense because there's no muscle that crosses the back half of it. So hypermobility of the pelvis is only going to come from altered mechanics of the feet, the knees, or the lumbar, or some type of altered force loading on that. That's why you got to look at the whole spine. So everything that you're listing here makes sense that your body would be experiencing the symptoms. But remember, these symptoms, the leg tingling, the not laying on being able to lay on your back, okay, without discomfort, the child's pose or hyperflexion, all of these things, and the signs of degeneration, that means that this has been a long-term problem. This is why you have to get static and stress x-rays weight bearing. What does that mean? That means you're standing up on the floor, no shoes, barefoot, and then you bend the spine to one side, take a picture, bend it to the other side, take a picture, then you can see the dynamic motion. Because if there is motion at these joints, then that means that the disc can still be viable because discs get their nutrients through the position and motion of those vertebrae. They have a horrible blood supply because they're under such a great force loading. So you change the position and motion of the vertebrae, you change the nutrients to it. And based on those, then you can predict how fast the person will recover or if recovery is possible. Question 4 from David Jr. Takandong 4176. And again, this was a very long question, but here's the bullet points. Fractured T12 in a helicopter accident in 2019. Feel like a lump or a bone down L1, L2. Recently suffered debilitating knee pain and now severe pain in both feet when walking. Works on a fishing boat and is a helicopter pilot, but can't work with all this pain. Wow. I mean, helicopter accident? Thank God you're alive, brother. Okay, that is a big deal. A big deal. So let's get you healthy. And knee pain, what I would always say is that knee pain, foot pain, you've got to look at the biomechanics. The T12L1, this is also can alter digestion. Now, your digestive tract is so much more than digestion. This is where neurotransmitters are produced. It's also where your body literally gets the raw materials to regenerate the tissue. And so any challenge at T12L1, this is literally the end of the spinal cord. So in that area, and this is super common with traumas that you're describing, because you've got an immobile or a very, very stable rib cage on top of a real mobile lumbar. And any type of compression injuries, I see this in motorcycles, car accidents, skydiving accidents, jumps and falls, super, super common. And an helicopter accident will qualify as that. Okay, where you got this cage, 12 rib cage, 12 ribs on either side, falling on that mobile lumbar, injuring that area. So number one, the knee pain and foot pain guaranteed is going to be coming from altered mechanics of the lumbar, altered mechanics of the pelvis, and also thoracic deviations. Now, we've got to get your body healthy. 3 things we got to fix: physical, chemical, and emotional stress. We're going to concentrate on the physical right now. Okay, number 1, you've got to look at the entire structure. You've got to stabilize that pelvis. Look at the pelvic health video. We've got to get bending and static films of the lumbar. You've got to look at that thoracic area. Now, knowing that you damaged that thoracolumbar junction, There may also be secondary issues in the middle of the rib cage. So we may have to take flexion or lateral flexion films of the rib cage area to see if there still is mobility that we can correct the problem. And then you've got to look at the cervical spine, because if there's forward head carriage, you've got a 12 to 18-pound head. And for every 1 inch the head's forward, the pressure on the discs double. That means that if you have a bowling ball of a head, or just think of a sledgehammer, your torso is about the length of a sledgehammer handle, and the head weighs about as much as a big sledgehammer. And if you put that sledgehammer forward just an inch, or an inch and a half, or 2 inches, that puts a huge amount of strain on the lumbar. And this is going to cause the body to adapt. So you got to look at the entire structure, static and stress x-rays of any area that presents itself on the x-ray. So that means you take a static one, you see a structural deviation, you've got to take stress x-rays of that area to see if there's still mobility. If there is mobility, beautiful. Then you can correct it. If there's not, you've got to correct the area above and below, because there can be a lot of fusions based on the length of time from the trauma to where we're correcting it. Then look at our knee health video. You've got to look at all of the joints in the body has hydraulic. That means they need fluid. Okay, and they get this synovial fluid that's in the joints, which is a superfiltrated blood. Now, under stress, physical, chemical, emotional stress, the blood becomes thick. And that thick blood typically can't filter out into the joints, so the joints can desiccate or dry up. So when we look at a knee x-ray, we're going to see if there's desiccation or drying up of that joint, it becomes closer. And that typically has to do with not the knee, but the dysfunction of the calf muscle. In that calf muscle, you've got left and right gastrocnemius, but you also have the soleus, and the soleus is a pump. And if you have altered biomechanics of the foot, where that foot can't dorsiflex or move correctly, then the pump on the back of the leg can't work correctly. So the foot altered mechanics, the calf altered mechanics, and the knee altered mechanics are typically going to have to do with lumbar issues from either compromising the nerve to that area, or it can be pelvic instability from the lumbar issue. So all of that, you've got to assess it correctly, the entire body. Then you can stabilize the pelvis, get to a corrective chiropractor that's going to take an x-ray, or a good chiropractor that's going to take an x-ray, do a post x-ray to document that they're fixing the problem, and also at the same time address the knee, which you can dangle the knee, put a weight on the knee, but it doesn't make sense to stretch the foot, restore the arches of the foot, restore the biomechanics. You cannot do those that work on the feet and the knees if you have compromised nerve supply that comes out of the lumbar. So you've got to address literally everything all at once. Then you have to change the sleep patterns. Sleep is when the body regenerates. Since you are in a chronic pain state, remember, you've got that automatic nervous system. One part keeps you alive under stress, the other part regenerates tissue. When you're in a sympathetic dominant or a stressed state, you got blood supply shut down to the gut. Means poor sleep pattern. Sleep is when the body regenerates. So look at our sleep restriction videos so that you can reset your circadian rhythms. Then you're a healthy guy. You need to work. You can't work because your body's not functioning. So there is going to be an emotional stressor. So we teach all of our patients neurolinguistic programming, but there's a lot of things that you could do. There's eye movement desensitization response. There's emotional freedom technique that you can tap. But find some method that works for you to reprogram that emotional component, change the sleep patterns, correct the structure, and then your body gets the best chance to regenerate. Question 5 from Trek Keto. For over 6 years, I've had sciatica on my posterior left thigh and a burning, pinching type of pain. It only does it when sitting or laying on my left side. What could that be? No one has been able to help me with this. Mind-blowing. The sciatic nerve has 5 nerve root origins from the sacrum and the lumbar. And when it's so frustrating, because when you're sitting on this ischial tube. And when you're sitting, if that causes pain, you're straining the ligament on the back half of that sacrum or the pelvis. And when you're straining that, if there is pain, it means the pelvis is unstable. I know what you want to say like now. Duh. Okay, so pelvises never malfunction. They're a perfect design unless there's a problem with the feet, the knees, the gait, how you're walking, and the lumbar. And I have never yet seen pelvic instability without a lumbar secondary component or primary component that the lumbar started, and then that led to the pelvic issue. So you have to look at everything. I mean, getting the good chiropractor to take a picture of the neck area, lateral, A to P, and stress x-rays to see what joints are moving. You have to look at the thoracic area, because if you have an alterations in structure of the thoracic area, that's going to change the force loading on the lumbar. The challenge that we have with a lot of doctors today is it hurts here, look there. No, that is so. We're talking really low level stuff. I mean, the really, really low level is pain. Here's a chemical to alter your awareness of that pain. That's a really, really low level. Okay. But when you're thinking that the sciatic nerve is a problem, is only a problem with the sciatic nerve, you're never going to get it better. Look at all pain, particularly sciatic nerve, knee pain, foot pain, back pain, neck pain, has not the issue, but has the alarm telling you that there's a dysfunction. And if this pain has been going on for a long time, that's going to start to affect how your body regenerates itself, because it's going to put you in that fight or flight state. The reason it hasn't been corrected and no one has been able to help you with that is because they're looking at the pain as the problem. The pain is the alarm telling you that there's a dysfunction of the system. And the system involves feet, knees, pelvis, lumbar, thoracic, cervical, sleep patterns, emotional health, nutrition, everything. You fix that body, then the body can regenerate healthy. So if your question wasn't answered here, check out the Dr. BVIP where I can speak more freely. And please subscribe and share this. God bless you. You're designed to heal. Stay healthy, my friends.